What I find fascinating is how rapidly, really in just the last few years, both the provider community and the payer community have come together to accept the challenge that we really do need to do something about decreasing costs, and that the way to do that is by improving quality. You know, it was only a few years ago that people were saying, well, maybe it's okay if we spend 25% of the GDP on health. That's a good way to spend money. You don't hear that kind of talk anymore. The combination of the recession and getting real, if you will, has meant that people are really seriously looking at this. And I think it's frankly very encouraging that we at least are having these kinds of discussions, that we realize we do have to do something about it. I think we've all finally gotten fed up with the amount of waste in the system and say it really is our obligation to do something about it. I would point out that value, which is the big buzzword now, value being quality and efficiency over cost, the things you need to do to improve value are exactly the kind of things we have to do for everything we want to do in safety. We're talking about making care more efficient. We're talking about making care more systematic and more effective. All this comes together in a couple of things we've seen in the last year or two. That wonderful article by Atul Gawande about McAllen, Texas, a town that is in the top tier, one of the highest costs of health care, which also has mediocre provision of services. And what's that all about? Versus the other end of the spectrum, which Don Berwick and Atul Gawande, Elliot Fisher, and McClellan, what's his first name? Not Scott. Anyway, McClellan, the former Mark McClellan, thank you, put together. They identified the top hospitals in terms of quality and cost, high quality and low cost, and they got 10 of them to come and meet and talk about what they did. And they called these, they wrote, some of you I'm sure read this, the name of the article was, how did they do that? The question is, how did these hospitals do that? And I think it's worth just asking that question, well, how did they do it? Well, what they found is that there were 4 characteristics of these 10 outstanding high-value hospitals, high quality, low cost. And they are leadership. Every one of them had a physician champion who pushed and made it happen. They were able to align their financial incentives. They used measurement and feedback so the doctors knew what they were doing. They had the information so they could respond to it. And we've learned from NISQIP, all you have to do is tell people how they're doing and they respond to it. And so feedback is a powerful way to improve quality. They use that. And then they engage the employers in the community to work together. So we have here a model of how we can do it. And this is what we're building off. We heard a wonderful talk by Susan DeVore at lunchtime about what Premier is doing in this and so forth. And it's building on these same basic principles. And then finally, I think the other thing, of course, is the new big idea is the Accountable Care Organization, and we're all rather holding our breath to see how that's going to work out. Now, if you look at all this, it seems to me that with regard to safety, there are several key policy questions. The first one is if we're going to reduce costs. I'm reminded of Uwe Reinhardt's comment, your costs are my income. And of course, that's exactly what it is. And so the policy question here is if we're going to reduce costs, whose income are we going to reduce? Who's going to pay for it? Who's going to be paid less? Well, if we believe that the way to do this is to get rid of unnecessary care, then all the specialist physicians who are providing unnecessary care are going to have their income reduced. The radiologists who are doing the unnecessary imaging that these physicians have requested are going to have their income reduced. The hospitals where all these people work are going to have their income reduced. The device and drug makers are going to have their income reduced. Interesting. Hospital example, there's been some recent evidence that with really intensive treatment and coordinated care, you can reduce hospitalization of patients with congestive heart failure by 90%. So the hospital succeeds in doing that. It loses its income. We've already seen that in treatment of asthma, have effective treatment for asthma and hospital income. So the question, the policy question for the hospital community, and you all know this far better than I because you're there, is, as Gary Gottlieb of Partners said, how do we do less for less? And let's be clear, it's going to be less. And the question is, what's the business plan for contraction? Aren't very many people have much experience at that. I think it's a fundamental issue. The big question, of course, is can we make these ACOs work? I think we can, but it's clearly not simple. It's not just a matter of how do you get everybody in an ACO, what do you do with the onesies and twosies and rural doctors, how do you do attribution, how do you do risk adjustment? There are 1,000 questions about how to make it work. So it's certainly the question of the hour is how can we make them work? And on top of this, we have a couple potential political monkey wrenches. I don't really think we're going to privatize Medicare. I'm not so sure about the Supreme Court. The Supreme Court could indeed say that mandatory insurance is unconstitutional. That would be very unfortunate, but we'll have to see.